Okay.
Should we start, Saphalta ma'am?
Then please introduce.
So good evening, respected seniors and my dear colleagues. Welcome on the academic platform Onco Ocean. It is a platform covering series of lectures formulated for MD and DNB students, residents. All the lectures are taken up by India's finest mentors, which gives fruitful learning experience to the PG training. Today's session will be dedicated on the topic role of systemic therapy in various stages of TNBC, that is EBC, LABCs and metastatic setting. For today's session, I would like to welcome our esteemed chairperson, Dr. Neha Gupta ma'am. Dr. Neha Gupta ma'am is a senior consultant and a DNB consultant, HOD, Department of Radiation Oncology at Apex Cancer Hospital, Varanasi. Ma'am has completed her MBBS from MLB Medical College, Jhansi, and MD from HGPGI, Lucknow. Ma'am has over 2 decades of experience in the field of oncology. She has completed her senior residency from HGPGI, Lucknow, had worked as a clinical associate from Fortis Hospital, Noida, and was a consultant at Indian Railways Cancer Center and Research Center, Lehertara, Varanasi. She's a member of AROI, UP AROI, and ECMO. She's published many articles in national and international journals. In field of radiotherapy, she's well versed with state-of-art technology, including high precise radiation techniques like IGRT, IMRT, SRS, brachytherapy, interstitial brachytherapy.
Thank you,
Very
Aditya,
warm
for your
welcome,
kind
ma'am.
words.
Dr. Neha ma'am, I would like to request you to introduce our speaker for today's session.
Hello,
Yes, ma'am, you're audible.
Aditya.
Yes, ma'am, you're audible.
Can you share the slide of Dr.
Yes,
Saphalta's
yes,
CV,
ma'am.
please?
Yes, ma'am.
Yeah, thank you. So it's an honor for me to introduce our guest speaker today, Dr. Saphalta Baghmar. And she did her MBBS from Devi Ahilya Vishwavidyalaya, Indore, in the year 2006. And then MD from AP Singh University, Reba, in 2009. Thereafter, she pursued her DM in oncology from All India Institute of Medical Sciences in the year 2014. And she has many gold awards and distinction. She had this distinction in pharmacology. And she did her first oral presentation and got her award in Indian Cancer Congress. She has many international as well as national to her. She has presented the Cancer Congress 2016, Barcelona, Spain. Thereafter, in Chicago, USA, in the year 2012, she presented the paper in ASCO. So, Dr. Saphalta, we are pleased to have you as a speaker. And can you please take the lead from now onwards?
Welcome,
Thank you,
Saphalta
Dr.
ma'am.
Neha, and thank you for giving me this opportunity, as well as Dr. Ankita, who invited me for this lecture. Uh, can I have my slides, please?
Yes, ma'am, just a minute. Yeah.
So, I was given a topic of triple negative breast cancer as a whole, but frankly speaking, each and every portion of it is a lecture by on its own of almost an hour. So I'll try to cover the landmark trial and the practice changing trials which we in the triple negative breast cancer, and try to summarize so that you will be able to understand what actually we have to do. So next slides, please. So my slides would be about a bit of, because staging you all know, previous classes you might have taken. This topic must be taken. Now I will give about brief overview of TNBC in India, its heterogeneity, which is specific for TNBC. Then the role of immunotherapy, PARP inhibitors and ADCs, and the possible algorithm. Next slide, please. So We next slide, please.
Yeah.
So we know that triple negative breast cancer is the most aggressive type of breast cancer, and uh, it has visceral metastasis. Like when it is ERPR positive patient, you will have more of a bone metastasis, but in triple negative breast cancer, you will have visceral metastasis more often. And 46% of these patients, they will be having brain metastasis in their lifetime. And but one thing more is that when it is triple negative breast cancer, that means these patients, they do respond to chemotherapy well, but then there are early relapses. So it is usually a dictum that whenever a patient of triple negative breast cancer is there, then it is like within 2 years, most of the relapses are within 2 years. And if at all, and then the relapse incidence decreases. And once it is like 5 years, then it becomes almost equal to that of the ERPR positive breast cancer. So first 5 years are crucial. Next slide, please. Then coming to the incidence of triple negative breast cancer in Western countries, it is more of a 15 to 20% of these patients, they do have triple negative breast cancer. But in India, it is almost like 30% of these patients. And as our patients almost a decade younger to that of the Western population, so incidence of triple negative breast cancer is also higher in our population. Next slide, please. And next slide. Next slide, please. So we also know that triple negative breast cancer is not a single entity. So actually, whenever there is a breast cancer, we talk about whether it is luminal A, which is having the best prognosis, ERPR positive. Luminal B, when it is said that their Ki67 is higher, ERPR expression is lesser than the 8 by 8 or 7 by 8, then HER2 positive, and then comes the basal like. So either it can be basal like or triple negative. So what we think? We think that triple negative breast cancer is synonymous to basal like, but it is not. Next slide, please. So there are certain differences, some similarities between the two. There's genomic instability, prevalence of high grade, markedly proliferation, and expression of EGFR, high frequency of germline BRCA mutation, and there is high prevalence of P53 mutation. There are a lot similarities, but no, there is. Next slide, please. Then, but they are not synonymous. 25 to 30% of TNBCs, they lack the genomic characteristics of basal like breast cancer. So what is this luminal A, B, C? We say it's luminal A, but then how it is diagnosed? It is through the genomic mapping. So whenever you map a TNBC, if you genomically map it, so 25 to 30% will not be having basal like morphology. And what are these tumors? These tumors have less proliferation. They are less responsive to chemotherapy as well. Next slide, please. So what did Lemon do? Yeah, Lemon study, what it did was it divided triple negative breast cancer into 6 different varieties. And they have a characteristic of each variety has certain characteristic. But then later on, next slide, please. So I will just enumerate those varieties, that is basal like 1, 2, then immunomodulatory, then mesenchymal stem cell like, or androgen receptor positive. Next slide, please. Next slide. Next slide. But then it was said that likely the immunomodulatory and mesenchymal stem cell like, they are part of the same spectra, and maybe it is like there was an impurities that time when it was enumerated, and it was when nomenclature was done. So later on, it was shifted that there are only 4 types of TNBC, and that is basal like 1, 2, mesenchymal, and androgen receptor expressing. And how they are different, they have been also like pathological CR rate is different. So 46% in basal like 1, basal like 2, it is 12% only. Mesenchymal, it is 29, and for LAR, it is 15%. Next slide, please. So we have for practical purposes, it is like 4 different types, because whenever we tell a patient, whenever we counsel a patient, and that triple negative breast cancers are a kind of cancers which actually respond to chemotherapy well. But we also have to know that we are not mapping all these tumors. So we don't know whether it is like basal like 1, 2, 3, or 4. So we don't know how much will be the pathological CR rate in these. So we have to counsel the patient this. Yes, it is chemosensitive disease, but there are certain patients who may not respond as good as other patients. Next slide, please. So yes, surgery is was the norm for any of the breast cancers. Chemotherapy part, it is slowly taking a front stage, and especially in HER2 positive breast cancers or the triple negative breast cancers, uh, neoadjuvant chemotherapy is very important. Next slide, please. So, what is the role of neoadjuvant chemotherapy? It serves as an in vivo sensitivity test, increases the rates of breast conservation surgery, facilitates the study of cancer biology, pathological CR, because we have certain things. Because if we achieve pathological CR, that gives us EFS benefit, OS benefit. So, neoadjuvant chemotherapy took center stage in triple negative breast cancer after there were multiple studies. This was a meta-analysis which was published for 27,000 odd patients. And they have shown that the patients who received neoadjuvant chemotherapy and had pathological CR, they have significantly better EFS as well as better OS. And you can see hazard was almost like 0.22. That is way good that we can even imagine. Next slide, please. But so that's why NCCN says that whatever you can see the last part, whenever it is triple negative breast cancer, even the patient who are having T1C disease, these patients should be given neoadjuvant chemotherapy. I'm not sure about it. T2, yes, but T1, there are certain debates which are ongoing whether we should give chemotherapy upfrontly or chemotherapy or we should do a surgery. But there are many aspects whenever we think of it. If a young patient is there and we are planning for kind genetic testing, and when we do genomic testing, because triple negative breast cancer, they have higher chances of having BRCA1 BRCA2 positive, and then we want that result to be out. Like it takes 3-4 weeks of for BRCA1 BRCA2 result. That time is almost that like that, and the patient wants, if at all it comes to be a BRCA1 BRCA2 positive, then they want to go ahead with the radical mastectomy and bilateral mastectomy, bilateral oophorectomy. In that case, we want some time. In that case, we may plan a neoadjuvant chemotherapy in T1C tumors. Otherwise, T2 and above, it is completely yes for neoadjuvant chemotherapy. T1C is a gray zone, and it's a part of debate in most of the meetings. Next slide, please. Now, here you can see, if a patient of a triple negative breast cancer, you give neoadjuvant chemotherapy and they achieve a pathological CRA, in that case, it is almost as good as other breast tumors. But if there is a residual disease, in that case, these are the worst tumors as compared to any other breast cancer patient. If HER2 positive breast cancer, they have residual disease, or hormone receptor positive patient, they have residual disease. But the TNBC with residual disease are the worst one. Next slide, please. So what we do, we try to make this pathological, more number of patients to have this pathological CRA. Now, PATH CR can be achieved. One thing is the baseline chemotherapy, which you might have already read in your previous lectures. Another important thing, which is especially in the triple negative breast cancer, that is addition of carboplatin. Like what we give in neoadjuvant chemotherapy, it is dose-dense paclitaxel and dose-dense adriamycin cyclophosphamide. Now, adding carboplatin with paclitaxel is important for triple negative breast cancer. And there are a few studies. I will highlight one study which was done by TMH. Here, Dr. Siddhi Gupta was the PI. And what they did was they added carboplatin in all the patients. And what they found is that when a patient who is younger, so 50 years or less, in these patients, when we add carboplatin, there is an EFS benefit of 18.5%. Pathological CR rate is increased by 18.5%. EFS is increased by 12.5% and OS is 11.2% increase. And that all the three were significantly better. So this is our usual practice that whenever we give neoadjuvant chemotherapy, we add carboplatin in these patients. Next slide, please. Now, another way of increasing PAT-CR in TNBC is immunotherapy. Next slide, please. So why we give immunotherapy to these patients? So these patients have higher immune cells, T cell infiltration is there. So that is the reason why immunotherapy is effective in triple negative breast cancer. So there are many studies which are ongoing as well as have been published. Almost 6 are there. But I would like, and this table summarizes them, but I would like to highlight the 2 landmark trial in neoadjuvant triple negative breast cancer. Next slide, please. So one is Keynote 522. Here, the patients were randomized to 2:1. They receive peclicarbo plus one arm received placebo, another arm received pembrolizumab. While during AC or EC, also one arm received placebo, another arm received pembrolizumab. So they completed four cycles of each, and followed by that, surgery was contemplated. And then later on, the people who receive the arm who receive pembrolizumab in neoadjuvant setting, they also receive adjuvant pembrolizumab. So 80% of all patients were PDL1 positive, and their primary endpoint was PAT-CR and EFS. Similarly, in the study IM Passion 031, here also same protocol were used, except pembrolizumab, atezolizumab was used. Here the PDL1 was almost, PDL1 positive was almost 50%. Here the primary endpoint was PFS. Next slide, please. Now, coming to the PAT-CR rate in both the studies. So you can see why after adding pembrolizumab, here we can see that by adding carboplatin, we achieved 18% more PAT-CR. Now, on carboplatin, if we add pembrolizumab, we are getting 13.6% more PAT-CR. Similarly, atezolizumab, it is like 16% more PAT-CR. But what happened with atezolizumab? Initially, the trial was with paclitaxel as well as with nab-paclitaxel. Nab-paclitaxel arm worked better. Paclitaxel arm did not work. So there were multiple debates happening, and finally, atezolizumab was taken back for this indication, triple negative breast cancer, and it lost its market. And by that time, pembrolizumab study, it showed its activity, and we all are using pembrolizumab. While atezo has again come back, but yes, we are practicing using pembrolizumab. Next slide, please. Now, another analysis, PAT-CR is fine. It is there. So it is like 15.5-month follow-up. And here you can see that even the PDL1 positive, yes, they are showing 14% increase in PAT-CR. But even in the patient who were PDL1 negative, then those patients also showed 18% increase in the PAT-CR. That's why when we advise pembrolizumab in the patients for neoadjuvant chemotherapy, in TNBC patients, we don't test for PDL1. All the patients, they are eligible for pembro. Next slide, please. And then it is like EFS data, which was 63.1 month median follow-up. And here you can see that there is an increase in EFS, almost like 9% EFS benefit at a median follow-up of 60 months. Next slide, please. And another data, which is very interesting, has come up, that there is a debate ongoing. Then when a patient who you have given pembro with neoadjuvant chemotherapy and the patient achieves PAT-CR, then in that case, whether we should continue pembro after this, pembrolizumab was given FDA approval in 2021. Next slide, please. Next slide. So we know NACT is important, and there are agents with which we can increase the PAT-CR, and then they are useful also. But yes, they yet to show an OS benefit. Next slide. So just one slide on adjuvant. So as such, most of the patients, they receive neoadjuvant therapy. If at all a patient who is not did not achieve PATCR, what do you do? Next slide, next slide. So there is a data, the CREATEX study. What it suggested is that whenever a patient who is not has residual disease, in that case, what we can do, that is we can give create capecitabine, and capecitabine is given for almost 6 months, that is completely 8 cycles. And what it has shown is that when it has shown a 5-year increase in DFS, and that is almost 7%. And in fact, it has shown OS benefit, and that is also 7%. So this is a landmark trial. So whenever there is a residual disease, what we do, we give uh, capecitabine. Now, there is also one query. If the patient has not achieved PAT-CR and patient is on pembrolizumab, then what to do? Then in that case, we add, if the patient is not is BRCA1, BRCA2 negative, in that case, we add capecitabine along with pembrolizumab. Next slide, please. Next slide. Now, BRCA mutation, and I'm taking this section in the adjuvant setting. So we have completed neoadjuvant. We know how the practice has changed, and the newer drug pembrolizumab in neoadjuvant setting. Now we are in the adjuvant setting. Adjuvant setting, capecitabine, the role of capecitabine we have seen. Coming to the BRCA. So you have, so all the TNBC patient, whatever is the age, so NCCN or any of the guideline, they suggest genomic testing. So what we do, we test for broad panel, but if the cost is a constraint, then BRCA1, BRCA2 should be done. And as such, only BRCA1, BRCA2 have some activity, like olaparib has activity in BRCA1, BRCA2 only. Rest of the mutation, there is no activity of olaparib or any other PARP inhibitor. Next slide, please. Now, prevalence of BRCA positivity, that is in HER2 positive patient, in hormone receptor positive patient, it is 3.7. While in TNBC, it is almost like 10 to 20% of these patients, they may be BRCA positive. And HER2 positive patients, it is rarely. So it is also said that when the patient is HER2 positive, you don't need to check for the BRCA1. But if there is a family history, strong family history, young patient, you should go ahead with that testing. Next slide, please. So important thing, whenever we give olaparib to the patient, it should be genomic mutation, BRCA1, BRCA2, so not somatic. Now, what is somatic and what is genomic? Somatic means when you test in the tumor tissue and blood is negative. In that case, it is somatic. That means that mutation has come up by its own later on. But when it is genetic, then in that case, it is when it is genetic, that means it is in the blood. It is in all the cells of the body. So this is an Olympia trial in which the patient who are BRCA1, BRCA2, and TNBC patient, you have to notice that if the patient has prior received neoadjuvant chemotherapy, then in that case, they should be no PAT-CR. If it is PAT-CR, then you don't need to give adjuvant olaparib. When it is non, then there is a residual disease, then in that case, PET-CR, then that is olaparib can be given. And if the patient has received adjuvant, if no new adjuvant was given, surgery was done, and then the patient comes to you, then in that case, if the patient is T2 or T2 or above, or if the patient is node positive, in that case, olaparib can be considered. Next slide, please. So this was the inclusion criteria in this study. And this was a second interim analysis with a median follow-up of 3.5 years. Here you can see that there is an IDFS benefit of almost 7%, 7.3%. And that is too good. That is also good to use this drug in an adjuvant setting. Next slide, please. Another IDFS was presented, and that was in last year, SABCS, and 2024. Here, 10-year update was given, and here also it is significantly better IDFS when the patients were given olaparib, and that is given for 1 year. Next slide, please. Then OS interim analysis was presented. It has shown 3.4% benefit. Next slide, please. Then the 10-year update was presented last year, and it is also significantly better. So, if a patient who has presented to you neoadjuvant chemotherapy done, surgery done, and has residual disease, in that case, uh, you can give olaparib to these patients. Next slide, please. Now, if the patient has taken pembrolizumab, then what you will do? In that case, pembro plus olaparib is continued. We give both of them. Next slide, please. So this is the diagram, the way we treat triple negative breast cancer early. If it is T1C, as I said, guidelines have included, but there are debate going on. So you give neoadjuvant chemotherapy, and then if it is or patient who is having any T2 or N1, any N positive, then in that case neoadjuvant chemotherapy along with pembrolizumab. So pembrolizumab is T2 and above, but if you are giving neoadjuvant chemotherapy in T1C patient, then in that case, there is no role of pembrolizumab. Okay, then surgery is done. If it is PAT CR, you complete pembro. If it is non-PAT CR, in that case, you can give capecitabine, or if it is germline BRCA positive, in that case, you give olaparib, and along with that, you complete the pembrolizumab for 9 cycles. Next slide, please. Now we have completed the EBC and LABC. Now we move forward to metastatic TNBC. Next slide, please. So, sorry. So these are the historical treatment options. And you all know Pecli, Carbo, Adriamycin, then capecitabine, gemcitabine, vinorelbine. These are the drug of choice.
Ma'am, are you there?
Yes, I'm there. I'm there. Am I audible?
Yeah, now you're audible.
Yeah, you are audible now.
Yes.
Yeah.
So, is it okay? Whatever I have said in previous 2-3 slides.
Yeah. This slide only.
Okay,
lost
okay.
It was only this slide which was your voice was not audible. You are not audible.
Okay. So these are the historical treatment options which we all know, that is paclitaxel, nab-paclitaxel, anthracyclines, capecitabine, vinorelbine. But then what is new in metastatic TNBC? Next slide, please. So historically, first line, what we used to give, either we used to give taxane to these patients or some platinum compound, gemcitabine, carboplatin, or paclitaxel with carboplatin. Anthracycline was first line. Later on, second line, capecitabine, or if you have given paclitaxel in the first line, then in the second line is gem carbo or lipodox and erboline. These were the second line options. Next slide, please. So there is a paradigm shift, in fact. So why we are having why immunotherapy is being used in TNBC? There are many mutations. And if there is like a TMB high, that is mutation burden is high, in that case, immunotherapy works. Expression of PDL1, T cell infiltrations. And we have higher number of patients of TNBC having BRCA positivity. So we have PARP inhibitors for these patients. And then we do NGS because there are many other targetable mutations like PIK3, AKT pathways, and immunotherapy as well. And there are ADCs also which has come up. Next slide, please. So coming to now immunotherapy in metastatic breast cancer. Next slide. So this is a landmark trial, that is Keynote 355. Here the patients who are previously untreated, locally recurrent inoperable or metastatic TNBCs. These patients were included in the study, and it is like whether it is PDL1 positive or negative, all the patients were included. So these patients were given chemotherapy, and that can be nab-paclitaxel, or gem carbo. And along with that, pembro was given, or placebo plus any of these combination. And pembrolizumab was completed for 35 doses. Next slide, please. So if we see that the patients who are having CPS score of more than 10, So then in that case, it has shown a significantly higher PFS, 9.7 versus 5.6. Next slide, please. Next slide. Now coming to OS, here also, previous slide, please. So here, this is CPS more than one. So more than 10, yes, it is significantly better. But even in more than one CPS score, it has shown a numerical benefit. It is 7.6 versus 5.6. But yes, you have to see that the p-value was 0.0014. And what they have pre-specified that p-value should be 0.0011. So that's why they said that there is a trend towards, but not a significantly better. But yes, whenever a patient there who is having CPS more than one, you can give immunotherapy to these patients along with the chemotherapy. Next slide, please. Oral survival, I'm not sure whether you are able to see or not, but then yes, if a patient who is having CPS more than 10, in that case, there is an OS benefit. While the patient who is having CPS less than if the patient is having CPS less than 1 in that case, or even in 1, then in that case, it has
You're
not
not audible,
shown.
Dr. Sapalta.
Hello?
You are not audible on this slide.
Uh, just a minute.
Now you're audible. Now you're audible.
Saphalta ma'am, are you there?
Now,
Hello.
am I audible now?
Now you're audible. Now you're audible.
Yes. So there is some network issues here. So here you can see in this slide that if a patient who is having CPS more than 10, then in that case it is showing OS benefit. But then if a patient is having CPS less than that, in that case it is not showing any OS benefit. So if a patient is landing between 1 to 10, in that case, you can tell the patient that yes, it is showing a EFS benefit, but not an OS benefit by adding immunotherapy to them. Next slide, please. So, but there are studies which has shown that these are the in vitro studies which has shown that whenever you give chemotherapy in later lines, there is a decrease in tumor infiltrating lymphocytes. There will be decrease in PDL1 expression. So, in that's why it is said that when if you want to use immunotherapy, you should use it in the first line setting, or in subsequent line of setting, the benefit of immunotherapy reduces. Next slide, please. Coming to BRCA mutation in the metastatic TNBC patients. Next slide. So this is a study that is what we read in the first trial in the adjuvant setting. It is Olympia A, and this is Olympiad D, Olympiad, that is AD. Here, the patients who have received 2 or more lines of treatment, these patients were giving olaparib, and the comparator arm, these patients, those were given capecitabine or vinorelbine, irulene. These were the drugs, and then you can see that it has shown some PFS benefit, and almost the hazard is 0.58. It has not shown any OS benefit, but this study has been criticized because the comparator arm, the chemotherapy was given just a weaker chemotherapies, while carboplatin was completely no for in this trial. And we know that a patient who is BRCA positive, in that case, carboplatin is a very important drug, and if the patient has not responded to carboplatin, there will be no use of even the PARP inhibitor. They will not respond to PARP inhibitor as well. So carboplatin is very important drug for triple negative breast cancer. Next slide, please. So there was an so OS And then as further subgroup analysis was also done, and they have shown if you use PARP inhibitor upfrontly, then in that case it has shown some benefit, OS benefit was there. But if you use it after chemotherapy, in that case it has not shown any benefit. So but why will we use olaparib in the first line? We use olaparib in the second line, third line, because it is a chemosensitive disease, and that gives better response as compared to PARP inhibitor. Next slide, please. So there is another study, that is Embraca, and that evaluated talazoparib. And this drug, this medicine drug was also is a PARP inhibitor, and it has also shown some EFS benefit, but not an OS benefit. Next slide, please. And in this meta-analysis, they compared both the drug. And what is here is, if the patient who is having HR positive, HR negative, hormone negative, triple negative breast cancer, both of the drug have shown benefit. But if the patient who is having HR positive, then in that case, Embraca, that is talazoparib, has shown benefit, but not the olaparib. If it is no platinum has been used, then both the drug have shown benefit. But if you have already given carboplatin, in that case, it has not shown any PFS benefit. Next slide, please. Now coming to next generation sequencing. So next generation sequencing is used in most of the carcinomas. Breast cancer, it is very well established to do it in the hormone positive breast cancer. While triple negative breast cancer also, it is very important, because the PIK3 mutation, AKT1 mutation, PTEN mutation, they are there in triple negative breast cancer, as well as about the AR pathway. So you can see this cartoon, and this was presented in ESMO Congress 2024. And here you can see that there are so many pathways that are activated in triple negative breast cancer, and we have targeted therapy for many of them. Next slide, please. So this is one study which was presented, Capitilo 290. This was also in ESMO 2024, in which capivasertib plus paclitaxel. Capivasertib is mainly AKT and PTEN pathway inhibitor. And this was given in first line in metastatic triple negative breast cancer. Next slide, please. So here, this is either the patient have received adjuvant treatment and then they have relapsed, or the patient who has upfront metastatic and have not received any treatment for metastatic disease. Here the patients were randomized 1:1 randomization. Either they have received paclitaxel or paclitaxel with capivasertib, and their primary endpoint was OS. Or if especially the patient overall population, as well as in the patients who are having PIK3C, AKT, PTEN pathway altered. Next slide, please. So here you can see that there is an EFS benefit whenever you give this drug, but then EFS, you have to know that it is 5.1 versus 5.6 months. So this is just half month benefit, and this drug is way too costly. And we don't have this drug in our country. And even if the patient who are PIK3, overall it has shown just half month benefit. But if the patient who are having this altered pathway, in that case, it has shown some 2 months benefits. So then if you come across a triple negative breast cancer, then this is an option. And these patients should be PD-L1 negative, because if the patient is PD-L1 positive, in that case, you should better go ahead with the immunotherapy along with chemotherapy. Next slide, please. But it has not shown any OS benefit, whether it is PIK3 mutation positive or negative patients. Coming to ADCs. So just a brief overview about ADCs. Next slide, please. So almost 100 of ADCs are in pipeline. There are many who are who have shown benefit, and there are almost 100 ADCs which are being yeah. So now in ADCs, it is what is ADC? That is antibody drug conjugate. What does it means? Antibody means if it is HER2 antibody, what we do is we attach antibody as against to the any of the receptor on the cells. So this is trastuzumab antibody is there. What is drug here? Then in that case, it can be either irinotecan, it can be any paclitaxel. These are the drug that is there. And then they are attached to this antibody through a linker. So what happens is that whenever there is a receptor positivity is there, that is HER2 receptor. Now, why I am talking about HER2 receptor in a triple negative breast cancer? Because here this ADCs, they work well whenever this is HER low. That is, you have seen that triple negative breast cancer is there and it is 1 plus. Then also we say it is a triple negative breast cancer. But if it is 1 plus, in that case, role of ADC is there. Now, so then it gets attached. This drug gets attached to the HER2 receptor, which is there in the cell, and it gets internalized. And there is an endocytosis. Later on, there is a lysis and the drug. You can see these small dots. These are the drugs, and then these drugs they go into the cell, and then there is a lysis. What also happens is that these drug they also go to they permeate the cell membrane, they go out, and later on there is also lysis of the nearby cells. So that is also called as bystander effect. Next slide, please. So TDXT, this is one of the practice changing magical drug now in breast cancer or many of the cancer. In GI cancers also it has got approval. So here the drug to the antibody ratio is 8, and it is a very potent drug, and it has also bystander killing effect. Next slide, please. So TDXT, it is being tried in HER2 low, that is IHC1 or IHC2 plus with the FISH negative, triple negative and breast cancer, which is we say as triple negative. And these patients, they were randomized 2:1. This is DBO4, that is Destiny Breast 04 study, which is a phase 3 study. TDXT is given 5.4 milligram per kg, and which was compared with chemotherapy. Next slide, please. It is second line and beyond. It is first line and beyond TDXT. So here you can see that in the second line setting also, it has shown a PFS of 8.5 months and an OS of 18.2 months. So here we are talking about a triple negative breast cancer, which is already progressed on the treatment, and then it is showing a OS of 18.2 months, and that is very good. Next slide, please. So this is another ADC, that is sacituzumab govitecan. It has also got approval in triple negative breast cancer. Here also the ratio is different, and the linker is different. The drug is different. This SN38 is kind of irinotecan. Next slide, please. So here the patients who are, it is in the third line setting, where is it 2 or more prior lines. So third line setting, so this is XN trial. Here the patients receive either sacituzumab 10 mg per kg on day 1 and day 8, and followed by that, which was compared to the physician's choice drug. Next slide, please. Primary endpoint was PFS, and here you can see that it has shown a PFS and OS benefit. So patient in the third line setting, PFS is 5.6 months and OS of 12 months. So this is another good drug in triple negative breast cancer, the ADCs. Next slide, please. So there are many drugs that has become up, like datotrastuzumab. So there are many tongue twisters, and patritumab deruxtecan. So there are many ADCs you will get to know in next 1 to 2 years itself. So possible algorithm for management of TNBC. Next slide. So if it is early breast cancer, and if it is patient is having T1A, T1B, in that case, you do surgery, you go ahead with it. If it is only T1A, you can consider. So usually what we do is NCCN recommends that it should be, if it is more than 1, in that case, you give chemotherapy. If it is between 0.6 to 1, then in that case, you can consider chemotherapy. We do in a young patients. If it is T1B, then in that case, adjuvant chemotherapy has to be given. And if it is 2PT1B and more, then in that case, you give chemotherapy. And if it is, and what it is there, if it is more than T2 and above, in that case, you can give olaparib if the patient is having BRCA mutation positive. Now, if the patient is having T1C and beyond, in that case, you give neoadjuvant chemotherapy. And along with that, you give immunotherapy. And if there is a residual disease, if the patient is having BRCA positive, then in that case, you give olaparib and you continue pembro for 9 doses, and then you continue olaparib. If the patient is not having germline BRCA1, BRCA2 positivity, in that case, you give pembro. Along with that, you add capecitabine. Next slide, please. So I was to make this next slide, but then I could not. So next slide, please. So then it is like, if a patient who is having metastatic disease, what you do, you test for PDL1. If it is PDL1 more than 1, then in that case, you can give the patient immunotherapy along with that. And you can also inform the patient that there's no OS benefit, PFS benefit is there more than 10. You can definitely add neoadjuvant chemotherapy and immunotherapy. Sorry, neoadjuvant not. It's like you add immunotherapy along with chemotherapy in these metastatic patient. And if the patient progresses, in that case, you have carboplatin based combination, gemcitabine, carboplatin, or you have lipodox along with carboplatin if you have not used in the first line setting. And you can go ahead with mutation testing. And in mutation, if there is mutation, then in that case, you have certain drugs. If at all, no, in that case, if there is any HER2 positivity, like even 1 plus, then in that case, TDXT is an option. And sacituzumab govitecan is an option in these patients in third line setting. Capecitabine is a wonder drug, and that is also useful. So this is how you treat metastatic carcinoma breast, triple negative. And yes, if it is BRCA positivity is there, in that case, you have olaparib. Thank you. So I can see one question about KI67. So yes, KI67 is very important factor. So whenever a patient who presents to us who is triple negative breast cancer, what we expect? We expect that KI67 will be higher. But none of the KI67, whether it is 10% or whether it's 20%, does not change any treatment. So whatever neoadjuvant chemotherapy or adjuvant chemotherapy you give. In hormone positive patients, yes, that time you think if a patient who is having 30-40% Ki67, in that case, if it is like there is less indication of an chemotherapy, then also you try to give chemotherapy, and if it's especially in the younger patient. But in triple negative breast cancer, you don't change your management according to the Ki67.
So it was a very nice presentation, Dr. Saphalta, very crisp and clear. I have a question. Just it's not a question actually. I just want to know what is your practice at your institute? How are you treating? Are you regularly using pembrolizumab and okay, BRCA1 and 2 testing? Are you regularly doing it in all the TNBC patients?
Yes, we do it.
Okay.
And in fact, we are writing a paper on it, that how many patients, almost 25% of the patients of that they are positive for BRCA positive.
Okay. So is it the germline mutation which you are testing or the somatic?
Germline, basically, germline is very important, so that because it is more of a, if you want to give olaparib, then also germline, and if you want to counsel the patient for the family, then also it is germline. So we give germline and test for germline.
Okay. Are you using pembrolizumab regularly?
Yes.
Okay. That's nice.
There's one more
Great.
question, ma'am.
So there was one question.
Is there any difference
the chat
between...
box.
I'm reading it out, ma'am.
Aditya, you are not audible. Is there any difference between AC followed by peclicarbo or peclicarbo versus AC? Probably you mean to say peclicarbo followed by AC.
Sequencing.
Yeah, sequencing. So see, there is no difference between them. Whatever you want, you can use. So uh usually most of the studies, what they do is they use AC followed by peclicarbo. Okay. Now the study keynote 522, they use peclicarbo followed by AC. So worldwide you can use anything. What I do is, see, peclicarbo is a easier drug. So I start with peclicarbo and then I switch to AC after 4 cycle. This is what. Sometimes and especially when logistic issues are also there, because like for AC, we need a center line. And if a and you need that center line for just 2 months, then what I do is I start with peclicarbo, which I can give by cannula itself. And for AC, I put a leader cath. We use it in, I was not using it previously, but I saw one time in a bone marrow transplant patient for harvest. Leader cath is used. And that leader cath is a kind of cannula and it goes to the central vein. So in that is like, it's a one, it's every time you have to get that procedure done, but it's very cheap. It just costs 6,000 rupees in our institute. So I get it done because every time it is 6,000, 6,000, and it is 24,000. And there is no issues with the handling because we always take it out. So patient can go, there's no chance of infection, no issues with the handling. For PIC line, it is almost like 30, 35,000. And every time you get the dressing done. So the cost increases and you just need that center line for 4 cycles. Then in that case, what I do is I use leader cat. So that's why I use peclicarbo first, and then just for 4 cycle, I give this leader cat I use, center line. This is how. इसको जुगाड़ू बोलते हैं, जुगाड़.
And same
Okay,
thing
so
is
why are
like,
you using central line for AC?
So
So for the risk of extravasation?
yes. So there are places where it is not being used. Like when I was at AIMS, we really used to have this. Nurses were very good; they were very trained, and we used to have this adriamycin from the cannula itself. But then, and even I was in US, and even in US, they were giving by peripheral line. But there are chances of extravasation when we come out, we work in a corporate practice. There, many of the nurses are new and they are not trained in managing these medication. In that case, it is better to have a central line.
So chemo port is not a very good option at your center. You are not
Yes,
putting it.
chemo port I am using left and right chemo port, but then it is just for 4 cycles. So why to get a chemo port done? Because chemo port is also a costly affair. There are many hospitals in which chemo port is like for 1 lakh. In our setting, it is 50,000. So I just compare. If I want to use it for long time, long term, so like trastuzumab I'm giving, and I'm giving it for the long time of a patient who is having metastatic disease where I will need central line for long time. In that case, I use chemoport. But if at all it is like just for 2 months, in that case, I can use Lidocath.
But then you are using pembrolizumab routinely, and it will be continued
For 9 months more. So it can be
9 months more.
for it can be given by peripheral line. So that is okay.
Fine.
There are no more questions in the chat box.
Aditi, you are not audible.
Yeah, right. Aditya, you are absolutely not audible.
Just, am I audible now?
Nah, yeah,
Yes.
you are audible now.
Okay, ma'am. Ma'am, I have a question. Like T2, clinically T2 onwards patients come after surgery, like TNBC, clinically T2. So in that setting, like for giving adjuvant chemo, which we follow like the standard protocol followed by radiation. So do you add pembro in that setting also?
No, there
Is
is
there
no
any role?
data. No, there is no data. It is only given when it is given in the new
A
adjuvant
new
setting.
adjuvant setting. Okay. There are no more questions in the chat box.
Hope people understood. I try to explain as if I'm
No, it was a
teaching.
very crisp and like very lucid presentation. Very
Any other
simple to
questions you
understand
can see
also.
in the chat box?
No, ma'am, there are no questions in the chat box.
Thank you.
Yeah.
Okay, then
Yeah.
we can conclude.
Yes, ma'am. So on this note, I would like to thank our chairperson, Dr. Neha ma'am, and our speaker, Dr. Saphalta ma'am, for this wonderful presentation in the session today. Thanks a lot, ma'am.
Thank you. Thanks a lot for inviting me.
Thank you, Dr. Sapalta. Thank you so much. Thank you, Aditya.
Thank you.